what can be done to improve the effectiveness of vaccines?
Yeah. Well, so one possibility is getting better vaccines, enhancing the vaccines to make it more immunogenic and that overcome this poor immune system that we have when we are getting old. And what we need in order to address all the issues that happens in the elderly, we need to enhance immune responses in the elderly. The vaccine, we need that it has more immunogenic. The vaccines need to provide broader protection, and especially important when there is a vaccine mismatch. We need to improve the direction of protection during the flu season because it's not enough like we have it right now with the traditional seasonal vaccines. And also reduce the disease burden. At the end, is that what we want, right? Improve the clinical outcomes against influenza. And in addition, they need to be cost effective. So what we have right now, traditionally we have inactivated flu vaccines, the trivalent influenza vaccine, which covers H1, H3, and influenza B. Quadrivalent influenza vaccines, they have been introduced now that covers the 2 different lineages of B virus that are circulating. But right now also there are new products that have been coming for the elderly, for the older adults. There is the adjuvanted trivalent vaccine that has been approved now in more than 30 countries to be used in the older adults. And there is the high-dose trivalent influenza virus vaccine, the TIV, which is only available in US and Canada, and is based on a high dose of the TIV. So the TIV, what it consists? Well, the TIV vaccines are inactivated vaccines that contains a component of H1, a component of H3, and a component of B virus. The standard TIV HA quantity per dose is 15 micrograms per 50 micrograms of HA for each of the strains that are being included. In this is a split vaccine, so it's partially purified. What has been done in the high-dose trivalent vaccines, TIV, is one induced 4 times the dose, so increase the number of antigen, and this is done by making some more purification and concentration of the standard TIV HA. Now, how the vaccines work, the antigen, when it comes, is being picked up by macrophages that give it to antigen-presenting cells, the disease that migrate to the lymph node. They talk to B and T cells, and here I'm representing the hemagglutinin of the virus. That is what is being delivered by the vaccine, one of the important antigens. And then these things become activated, the T and B cells, specific for influenza virus. Hemagglutinin becomes activated. They make plasmablasts, the B cells that at the end finish in plasma cells and in memory B cells that produce antibodies against the hemagglutinin of the virus. And there is also memory T cells that are being then later on is going to be helping also for a better protection. But the important thing are the antibodies that are induced by the vaccine. We have some non-neutralizing antibodies that are induced, and now some neutralizing antibodies that are antigen-specific. And antigen-specific meaning strain-specific. And in general, the vaccines, like we have in the TIVs, they produce a very specific response with antibodies mainly against the strain that is being vaccinated. Now, in the case of the adjuvanted TIV, adjuvant is simply mixing the typical TIV with an adjuvant, in this case MF59. And MF59 consists mainly of an in-water emulsion that consists of squalene and several detergents. Is perfectly safe. It's based on a metabolite that is produced in our body. And the action of the adjuvant is going to be, so that was what happens with normal vaccine. Now, adjuvanted, when you add MF59, what happens is that MF59, the adjuvant, is going to produce a more pro-inflammatory, more stimulation, macrophages and antigen-presenting cells, which result at the end in more stimulation of more B cells, more B cell lineages, with more T cell help that is being generated, with production of more antibodies, but not only more antibodies against the same epitopes that traditional vaccine, not adjuvanted, induce, but also some of these antibodies now are starting to see some of the cross-reactive antibodies with drifted strains. So that means that results in more antibodies targeting neutralizing epitopes in hemagglutinin. Also, some of them may cover some of the drifts that happen every year. And this is illustrated in this study by Ansaldi, how this does more breadth of protection. So we have here the vaccine response. In this case, is in the amount of seroconversion that we get in this study, with the vaccine that is a vaccine that is a 2004 vaccine. And we have around same level of seroconversion in both the elderly as well as the young people. But as we compare this antibody response against strains that are drifted in the previous strain, 2003, we start to see that there is a gap in the case of the use of the non-adjuvanted vaccine, and that you get much better breadth with the adjuvanted vaccine. And this is more dramatic as there is more drift, so you compare with more drifted strains of 2007. Still, the seroconversion that we get with the vaccine against in 2004 when you use adjuvant is much, much better than seroconversion. This is from 20% to 80%, the seroconversion that you get in the not use of adjuvant. So there is more breadth, and there is also better antibody response.
Thank you very much. Do come and rejoin the group. Thank you. So we've been hearing then about the burden of the influenza in the elderly. We've been hearing then, thank you, about the impact of the waning of the immune response. And here, thank you very much, something on the mechanisms of action of enhanced vaccines.